Hi everyone, here is Evelyn and I's presentation on personality disorders. Just our table of contents, we'll be going over general diagnostic criteria, impact on occupational performance, different settings and impact on service delivery, intervention techniques, and then we'll have some resources for you guys, and then our list of references. So to start off, a definition of a personality disorder. So a personality disorder is an enduring pattern of inner experience and behavior that deviates markedly from the expectations of the individual's culture, is pervasive and inflexible, has an onset in adolescence or early adulthood, and is stable over time and leads to distress or impairment. And that's according to the American Psychiatric Association. Then for personality disorders, there are three clusters. So cluster A includes paranoid, schizoid, and schizotypal. Cluster B is antisocial, borderline, histrionic, and narcissistic. Cluster C is avoidant, dependent, and obsessive compulsive personality disorder. How the clusters are formed. So they're formed based on common symptomatology. So for cluster A, they're grouped together based on odd or peculiar behaviors. Cluster B, they typically have more flamboyant or dramatic behaviors. And then cluster C is based on anxiety or fears. Risk factors for personality disorders. If someone has experienced adverse experiences in adolescence, genetics is always a big one. And more specifically for personality disorders, it's affecting the serotonin system and stress reactions. Also, brain deficits, commonly in the prefrontal cortex and the serotonin production. Childhood trauma, so like childhood malnutrition or maltreatment. And then, of course, family influences. Anhedonic parents are likely to have children with cluster A personality disorders. And the anhedonic means that, like, both parents, it's hard for them to find pleasure in activities. And then also parenting style. General etiology, the two main ones for many of the personality disorders is genetic or biological factors and or environmental factors. So etiology for some personality disorders is well researched and known compared to others. And all of the personality disorders, etiology is related to a combination of genetic and or environmental factors. But for many, there's no like set specific cause. It's kind of up in the air and unknown. So the DSM-5 diagnostic criteria, this is for general personality disorder, and then we'll have a handout explaining the criteria for each disorder and each cluster. So for general personality disorder, it's that they have a significant impairment in self, such as self-identity or self-direction, and interpersonal functioning like empathy or intimacy. One or more pathological personality trait domains or trait facets, the impairments in personality functioning and the individual's personality trait expression are relatively stable across time and consistent across situations. The impairments in personality functioning and the individual's personality trait expression are not better understood as normative or for the individual's developmental stage or sociocultural environment. And E, the impairments in personality functioning and the individual's personality trait expression are not solely due to the direct physiological effects of a substance such as drug abuse or medication or a general medical condition like severe head trauma. Overall general impact on occupational performance, of course, it varies between clusters and diagnoses, but these are some common similarities that you might see between each cluster. Inaccurate perception of self and others, inadequate social skills, poorly developed personal values and goals, and poor self-esteem. So here's more of a breakdown of the impact on occupational performance in each cluster and in each different personality disorder. So for paranoid, we might see work, leisure, social, and all patterns are impacted, and along with processing communication skills. And that's the same for schizoid as well. And then for schizotypal, we'll see impairment in work, leisure, social, and ADL and IADL patterns, and again with process skills. For cluster B, For antisocial, we'll see possibly a negative impact on work, leisure, social, and IDL, specifically financial and money management patterns, and then habits and roles emphasize illegal behaviors. For borderline personality disorder, again, there will be an impairment in work, leisure, social, and ADL and IDL patterns. Processing communication skills and roles, habits, and routines will also be negatively impacted. For histrionic, work, leisure, social, and communication skills, again, and patterns may or may not be impaired. For narcissistic, social, work, and possibly sometimes leisure will be negatively impacted. And then roles are impaired by their grandiosity. And then for cluster C, avoidant, social, and possibly work and leisure are not impaired despite the common lack of communication skills with this personality disorder. And most cases, patterns are not severely negatively affected. For dependent, social and possibly work and leisure will be impacted, and so will processing communication skills again. And for obsessive compulsive personality disorder, work, leisure, and social skills are impacted. They have excessive patterns and are rigid. They lack flexibility. Skills are not severely negatively affected, and obsessive compulsive is potentially the most disabling in this cluster specifically due to those excessive patterns and rigidity in their daily routines.
Okay, so the different settings that you'll see people with personality disorders in is going to be inpatient, outpatient, acute care, psychiatric or mental health settings, and also at nursing homes. Because personality disorders occur all throughout the lifespan and they're just so prevalent, 12.6% of the population have a personality disorder, you will most likely see people in and out of the hospital, just all over, and also in mental health settings, nursing homes, just everywhere. All right, so the impact on service of delivery, we broke it up into different clusters. So for cluster A, you'll see these people have more irritability and suspicion. They won't participate in competitive activities, so they don't thrive in group settings. They prefer solitary activities, emotional isolation compared to group activities. You'll see that they have cognitive disorganization, specifically for schizotypal personality disorder, not the rest of the personality disorders associated with cluster A, just for schizotypal. But that's important to recognize. And then overall social participation challenges for cluster A. All right, so for cluster B, this is where the behavior starts to get a little bit more aggressive. They may lack depth and consciousness. They'll have slow executive functioning, poor attention, poor short-term and working memory, and also impulsivity deficits, which leads to more risky behaviors. You'll see they have unstable relationships, specifically people who are diagnosed with BPD. They have extreme sensitivity, so trying to do constructive criticism may not go over very well. They may take it very harshly. Group therapy might not be the best intervention, specifically for people with histrionic personality disorder, because they thrive off of attention and affection from other people, and they also tend to have more of a lack of empathy for this cluster. So for people who are diagnosed with personality disorder specific to cluster C, you'll see that they usually lack some emotional skills. They have more anxiousness in social settings, and specifically for people with obsessive compulsive personality disorders, they really like strict settings and rules to follow throughout the day. So disrupting that setting will result in disorganization. So some intervention techniques that we can do to help some of the people diagnosed with personality disorders are dialectical behavioral therapy. This really helps with cluster B, especially borderline personality disorder, because of their suicidal ideation and suicidal tendencies. Cognitive behavioral therapy, this works for all of them, clusters A, B, and C. Some of them benefit more from psychotherapy, which targets behaviors more than cognitions. So specific to behaviors, you'll see this with cluster A, B, and C. Usually it's going to be paired up with psychotherapy and medicine. With any mental health disorder, pairing up therapy and medicine is usually the best bet. And then we try to do group therapy and social skill training for all clusters just so they can get that social participation and maybe reading more social cues and understanding more emotional recognition from other people and themselves. And so bringing this back to OT even more, well, we can work on our coping skills, behavioral training. This could be seen for like people with histrionic personality disorder. So instead of flirting with someone, what can we do that's acceptable? Social skills training, building self-esteem. You see a lot of people who are very anxious or very ashamed of their personality disorders, creating personal boundaries, values, and goals. You can see this a lot for cluster B and C. And understanding themselves emotionally and cognitively. So knowing what they've done and knowing how they can move forward and where they're at right now. And some of the resources we have, Peyton made this awesome handout that's kind of outlining the different criterion for the different clusters and specific personality disorders. We have some articles here for OT interventions with women with borderline personality disorder. Women are diagnosed a little bit more, so we'll see it like that, but it's also important to recognize men. Personality disorder, impact on life balance and how we can kind of understand that. And then here's a little quick article on the overview of personality disorders. You compare that with a video. There's a crash course on personality disorders that we found, a video about the different clusters and a rundown of personality disorders, and also a couple of interviews of people with personality disorders, schizotypal and borderline personality disorder, so we can get a better understanding of how they function, what they might sound like, and what they might look like, just some behaviors that they're exhibiting. And then our 2 multiple choice questions are, how could OTs implement social skill and behavioral training if the individual does not participate in group settings? And then how can a therapist use their therapeutic use of self in interacting with an individual who is suspicious, irritable, and struggles with reading social skills? And there are our references. So thank you.